Welcome, everyone. Have you ever found yourself in a situation where you thought you understood something completely, only to have your perspective flipped upside down? That's exactly what happened to me when I transitioned from being a nurse to experiencing menopause myself. Today, I want to share my journey and the profound lessons it taught me about compassion, empathy, and the human experience. As a nurse, I spent years caring for patients, often feeling like I had a solid grasp on their struggles. I was trained to provide comfort, support, and medical care. But nothing could prepare me for the emotional and physical roller coaster of menopause. Suddenly, I found myself on the other side of the stethoscope, and it changed everything. Menopause is often shrouded in stigma and misunderstanding. Many people view it as a taboo topic, something to be whispered about rather than openly discussed. But it's a natural phase of life that affects half the population. I realized that my experience could help break down those barriers and foster a deeper understanding of what so many women go through. During my transition, I faced a myriad of symptoms: hot flashes, mood swings, and sleepless nights. Each day felt like a new challenge, and I often found myself feeling isolated and misunderstood. It was a stark contrast to my professional life, where I was the one providing care and reassurance. This shift made me acutely aware of the importance of compassion in healthcare and beyond. One of the most significant lessons I learned was the value of listening. As a nurse, I often thought I was a good listener, but my experience as a patient taught me that true listening goes beyond hearing words. It's about being present, acknowledging feelings, and validating experiences. When I opened up about my struggles, I discovered how powerful it was to have someone truly listen without judgment. This realization inspired me to bring that same level of empathy to my practice. I also learned about vulnerability. In my role as a nurse, I often felt the need to project strength and confidence. However, experiencing menopause stripped away that facade. I had to confront my own vulnerabilities, and in doing so, I found a deeper connection with my patients. It reminded me that everyone has their battles, and sometimes sharing our struggles can create a bridge of understanding. Another crucial lesson was the importance of community. During my journey, I sought support from friends, family, and even online forums. I discovered that sharing experiences with others who were going through similar challenges was incredibly healing. It reinforced the idea that we are not alone in our struggles. This sense of community is vital in healthcare, where patients often feel isolated in their experiences. Encouraging open conversations can foster a supportive environment where everyone feels seen and heard. As I navigated the ups and downs of menopause, a profound realization emerged: the impact of language on healing, understanding, and human connection. At first glance, it might seem like a small detail in the vast landscape of healthcare, but I came to understand that words are not just tools for communication. They are instruments of either connection or disconnection, empathy or indifference, comfort or confusion. This awareness didn't arise from a textbook or a seminar. It came from lived experience, my own. Before menopause, I often communicated with patients using terminology I had been trained to use: medical terms, clinical phrases, efficient shorthand designed for documentation and clarity. While this language was precise and functional, I came to realize how much it could unintentionally distance patients from their own care. For years, I assumed that if I explained a diagnosis or treatment clearly, at least from a medical standpoint, I was doing my job well. But when I found myself on the other side of that dynamic, when I became the one trying to make sense of changes in my own body, I saw things differently. Suddenly, I was the one hearing terms like perimenopausal symptoms, hormonal fluctuations, or vasomotor instability, and feeling utterly disconnected from what those words actually meant in the messy, lived reality of my day-to-day life. It wasn't that the information was wrong, it was just distant. It didn't acknowledge the emotional complexity I was facing, the disorientation of mood swings, the exhaustion of sleepless nights, the quiet dread of unpredictable hot flashes in public spaces. These experiences weren't simply symptoms. They were moments of vulnerability that needed recognition and validation. In that space of personal vulnerability, I began to reflect on how I used language in my professional role. Was I, without realizing it, Dismissing people's pain by reducing it to medical terms? Was I accidentally silencing their stories by speaking in ways that didn't invite openness? These questions haunted me, not out of guilt, but out of a desire to do better, to speak better. So I made a conscious decision to change the way I spoke to patients. I began choosing words that were grounded in empathy, words that translated clinical understanding into human connection. Instead of saying, "This is a common symptom of hormonal decline," I started saying, "Many women feel overwhelmed by this. You're not alone in it." Instead of calling something a normal stage of aging, I would say, "I know this can feel unfamiliar and even frightening. Let's talk about what it's been like for you." That small shift, from abstract, impersonal language to authentic, relational conversation, became a turning point, not just in how I practiced nursing, but in how I understood human connection. At first, it seemed like a subtle change, almost too simple to matter. I replaced clinical terms with more relatable language, softened my tone, and gave patients more space to speak freely. But what followed was far more powerful than I ever anticipated. Almost immediately, my patients began to respond differently. I noticed a visible change in their body language, the way their shoulders relaxed, how their posture shifted from guarded to open, how their eyes met mine with less hesitation. They weren't just tolerating appointments, they were engaging. They started to share not only their symptoms, but also their stories, the backstories, the context, the emotional weight that so often goes unspoken in traditional medical settings. I remember one woman who came to me struggling with severe insomnia and anxiety. She had seen several providers before, each of whom had prescribed medications and recommended lifestyle changes. But none had asked about the emotional toll these symptoms were taking on her life. When I gently said, "This must feel exhausting. How has this been affecting your everyday life?" Her expression changed. Her eyes welled up with tears and she began to speak. Not just about her sleep issues, but about her fears, her sense of inadequacy at work, and the strain on her marriage. That simple prompt, grounded in empathy rather than medical instruction, opened a door that had remained closed for years. That encounter, and many like it, reinforced for me the idea that patients aren't just looking for solutions, they're looking to be seen. Clinical accuracy is vital, of course, but emotional validation is just as important. When patients feel safe enough to express what's really going on beneath the surface, we gain access to the full picture, and only then can true healing begin. The irony was not lost on me, and still isn't. I had spent years immersed in the rigorous training of nursing, learning how to read and interpret data, blood pressure numbers, heart rates, oxygen saturation levels, lab results, diagnostic codes. These were our metrics. These were the vital signs that, in theory, told us the most about a patient's condition. They were concrete, measurable, and quantifiable, evidence we could chart, track, and base decisions on. I was taught to trust them to let the numbers guide me. And for the most part, they did. They helped save lives, monitor treatment progress, and provide clarity in clinical decision-making. But over time, and especially during my own journey through menopause, I began to see a striking paradox emerge. Some of the most important signs a patient gives you are the ones that never appear in a chart. They aren't recorded in electronic medical records or flagged by diagnostic software. Instead, they emerge in silence, in nuance. In subtle shifts that reveal the emotional and psychological layers of a person's experience, if only we're trained to notice. I started to pay closer attention during patient interactions, not just to what was said, but to what was not said. A pause before answering a simple question, a glance downward when recalling a symptom, a tremble in the voice when describing a recurring pain. These micro-moments told me things a stethoscope never could. They spoke to uncertainty, fear, shame, or long-buried emotional wounds, and they only surfaced when a patient felt truly safe. This was the kind of diagnosis that demanded something deeper than medical expertise. It required emotional attunement. It required me to become as fluent in human behavior as I was in pathophysiology. And this fluency didn't come from a textbook or clinical guidelines. It came from being present, truly present, with another human being in their moment of vulnerability. One patient in particular stands out. She came in for what she described as just headaches. But her tone was hesitant, her answers clipped, her gaze flickering. There was something beneath her words that needed attention, or peppering her with symptom-specific questions. I simply said, "Would you like to tell me what's been going on lately? Not just the pain, but anything else on your mind?" She exhaled, deeply, and began to unravel the emotional toll of a recent divorce, financial stress, and the weight of single parenthood. Her headaches weren't just physical, they were psychosomatic echoes of overwhelm and grief. There were no boxes to check for those revelations, no ICD-10 code captured what was happening in her life. But in that moment, I understood the true meaning of a vital sign. Vital signs, I realized, aren't just blood and biology, they are anything that tells us about the vitality of a person's lived experience. This became even clearer during my own transition into menopause. I remember being asked by a clinician to rate my hot flashes on a scale of 1 to 10. But how do you assign a number to a symptom that makes you feel like you're being consumed from the inside out, in public, at work, while trying to pretend you're okay? It wasn't the intensity of the heat that was hardest to manage. It was the fear of losing control, the embarrassment, the isolation. None of that fit into a scale. None of it was chartable. Yet all of it was vital to understanding what I was going through. Experiencing that disconnect firsthand transformed how I approached others. I began to listen differently, not just to facts, but to emotion, metaphor, silence, and resistance. For example, when someone said, "It feels like something is pressing on my chest," I didn't just consider cardiac causes. I wondered, what's weighing on your spirit? When a patient described fatigue as a fog I can't shake, I asked about their emotional climate, not just their iron levels. These metaphors were not just descriptive, they were diagnostic pathways into the emotional truth of their health story. That's when I truly began to understand the emotional diagnostics that exist beyond the clinical realm. And in many ways, they are more difficult to interpret than any EKG. There's no chart for emotional shame, no baseline measurement for loss of dignity, no numeric trend for hope or hopelessness. These signs live in the cadence of a conversation, in the small confessions that slip through guarded smiles, in the tears that fall when you least expect them. But here's the catch. These signs don't appear unless the patient trusts you enough to be real. Trust is the prerequisite. Without it, people stick to safe answers. They say what they think you want to hear. They minimize or downplay their suffering, fearing dismissal or judgment. That's when you get the superficial report. "It's fine, I guess I'm just tired. It's probably nothing." But when trust is present, when patients sense that you are with them, not just examining them, they offer up the unfiltered truth. That's when healing begins. This trust isn't won by credentials or efficiency. It's earned through presence, consistency, and attuned listening. And once it's established, the depth of information that emerges is staggering. A patient may finally admit that their pain worsens when they return home to a toxic environment. Another may acknowledge that they've stopped taking their medication because of side effects they were afraid to mention. One might share that what they really need isn't another prescription, it's permission to rest without guilt. All of this insight, this human data, arises from the space between words, from what isn't charted but profoundly matters. In this way, I've come to see every patient interaction as a layered narrative. There's the official story, what gets written down, and then there's the real story, unfolding moment by moment, if I'm attentive enough to witness it. This kind of attentiveness demands something rare in modern healthcare: slowness. Not inefficiency, but intentional slowing down to create room for what matters most. I had to unlearn the instinct to rush, to fix, to speak. Instead, I learned to pause, to observe, to invite. And in doing so, I came to appreciate a deeper truth. Healing is not just about what we do, but how we listen. The charts will tell you what's measurable, but only the patient can tell you what's meaningful. And often, it's what's unspoken that speaks the loudest. So while I still value every tool of the trade, my assessments, labs, and diagnostics, I now understand that some of the most vital signs of all are emotional, intuitive, and relational. They exist not in machines or numbers, but in the sacred, fragile, powerful space between one human being and another. And that, I believe, is where true care lives. And trust, I realized, is not something you can demand. It's something you cultivate, slowly, intentionally through language that affirms rather than alienates. Every time I chose to say that sounds really difficult instead of that's a typical symptom, I was signaling to my patients, you matter, your experience matters. Every time I paused to ask, what's been the hardest part for you? Instead of pushing for a checklist of symptoms, I was prioritizing the person over the problem. And over time, this approach didn't just change my relationships with patients, it changed them. Many began to articulate their symptoms with greater clarity. No longer bound by the fear of being dismissed, they described their experiences in vivid, personal terms that gave me far better clinical insight than any intake form could offer. One woman described her hot flashes not as episodes of heat, but as sudden waves that make me feel like I'm unraveling from the inside out. Another explained her mood swings by saying, it's like I'm watching someone else take over my body, and I'm yelling from behind glass. These descriptions were not only emotionally rich, but diagnostically helpful. They told me far, more than numbers on a chart ever could. Patients also began to share things they had never told another provider: deep fears, past traumas, even cultural beliefs about aging, menopause, and womanhood. These revelations were possible only because they felt emotionally safe, and that safety was built not through authority or credentials, but through compassionate presence and language that invited openness. I'll never forget a patient who had been experiencing chronic pelvic pain, but had avoided seeking help for over a year. She told me, after a few visits, that she had been afraid of being labeled dramatic or attention-seeking, as she had been in the past. But after a few simple affirming exchanges, such as me saying, "You deserve to be taken seriously," she allowed herself to speak freely, and we were able to address not just her physical pain, but also the psychological distress that had accumulated over time. That's the power of relational language. It validates not just the condition, but the person living with it. It tells them, you're not just a case file or a number, you're a whole human being whose story matters. From a practical perspective, this shift also improved outcomes. Patients who felt heard were more likely to follow through with treatment plans, more likely to return for follow-up visits, and more willing to ask questions. This wasn't anecdotal, it became a pattern. They took ownership of their healing because they felt like respected participants in their care, not passive recipients of medical advice. In some ways, I felt like I was relearning nursing from the inside out. Began to understand that technical knowledge must always be coupled with emotional intelligence, and that language is the bridge between the two. It doesn't take longer to be kind. It doesn't delay care to be thoughtful. If anything, it accelerates healing because it aligns the clinical with the human. This realization also reshaped how I trained others. I started mentoring younger nurses and interns, teaching them not just how to perform procedures or follow protocols, but how to speak with intention. I encouraged them to replace phrases like, "It's nothing to worry about," with, "Let's walk through this together." I challenged them to move away from language that minimized and toward words that empowered and connected. And perhaps most importantly, I began using this language with myself. During the more difficult moments of menopause, when I felt overwhelmed, anxious, or disconnected, I started applying the same principles inward. I stopped calling myself weak or overreactive. Instead, I'd say, "You're navigating something real. Be gentle with yourself." That self-compassion, born from patient compassion, became a source of renewal. In retrospect, this evolution in my use of language taught me a profound truth. Words shape the healing environment. They influence how safe a person feels, how willing they are to open up, how much they trust, and ultimately, how well they heal. So yes, that small shift in how I spoke may have looked insignificant on the surface, but in practice, it changed everything. It deepened relationships, unveiled hidden stories, and turned routine appointments into moments of genuine connection. In those spaces, healing wasn't just a clinical outcome, it was a shared experience built word to the invisible weight language can carry, especially in conversations around menopause. Too often, it's framed with words that carry negative connotations: decline, loss, deficiency. But what if we changed the narrative? What if we used words like transition, transformation, or even renewal. These aren't euphemisms. They're reflections of the real and complex nature of what women go through. Menopause is not an ending. It's a redefinition. The language we choose should honor that. I began experimenting with how I described menopause to my colleagues as well. I shared stories, used metaphors that captured the emotional landscape of the experience, like comparing a hot flash to a storm that comes without warning, or describing mood swings as waves that demand presence rather than resistance. These simple metaphors helped even seasoned practitioners connect to the human side of what they were treating. I also realized that language shapes how people see themselves. When a woman hears her body described as failing or breaking down, she may internalize shame or helplessness. But when we say, "Your body is responding to natural changes and it's okay to feel off balance," we give her permission to be kind to herself. That shift in self-perception can be the beginning of healing, not just physically, but emotionally and spiritually. In one memorable case, a patient came to me visibly distressed. She had been told by another provider that her symptoms were just menopause, and that she'd have to learn to live with it. Those words, though likely intended to be pragmatic, had left her feeling dismissed and hopeless. When I sat with her, I chose a different approach. I said, "This transition is affecting your life, and it deserves attention. You shouldn't have to just endure it. Let's work together to find what brings you comfort and balance." She burst into tears, not out of sadness, but relief. That moment taught me that language can either close a door or open a space for healing. This evolution in how I use language also spilled into how I speak to myself. During the hardest days of menopause, I began practicing compassionate self-talk. Instead of criticizing myself for being forgetful or irritable, I started saying, "This is a hard day, and you're doing the best you can." That internal shift, that gentle vocabulary, created more space for self-love. It reminded me that compassion doesn't begin in the clinic. It begins at home, within our own minds. In healthcare, we often talk about evidence-based practice, but we don't always acknowledge the evidence of emotional truth, of lived experience. Language is where those two worlds meet. Science tells us what's happening in the body. Language tells us what it feels like. And in the end, healing depends on both. Through this journey, I also became an advocate for linguistic inclusivity. I began mentoring younger nurses, encouraging them to move beyond clinical checklists and to engage patients as whole people, with stories and fears and dreams. I emphasized the power of using affirming, respectful, and culturally sensitive language, especially for communities that are often marginalized or underserved. Words, after all, carry the history of trust or betrayal. Ultimately, this lesson on language has reshaped my approach not just to nursing, but to life. Whether I'm speaking with patients, colleagues, friends, or even strangers, I try to speak in ways that honor human dignity. I try to replace judgment with curiosity, replace assumptions with questions, and replace distance with presence. And whenever I catch myself reverting to detached or clinical phrasing, I pause and ask, would these words make me feel seen if I were on the receiving end? In this way, menopause didn't just change my hormones, it transformed my heart, my voice, and my practice. It reminded me that healing isn't just about medications or procedures. It's about the stories we tell, the words we choose, and the compassion we extend, one conversation at a time. Moreover, my experience taught me about the importance of self-care. As a nurse, I often prioritize my patients' needs over my own. However, going through menopause made me realize that taking care of myself was essential for being able to care for others effectively. I learned to carve out time for activities that brought me joy and relaxation, whether it was reading a book, practicing yoga, or simply enjoying a quiet moment. This balance is crucial in any caregiving role, as it allows us to show up fully for those we serve. Throughout this journey, I also encountered moments of humor and lightness. While menopause can be challenging, I found that laughter was a powerful tool for coping. Sharing funny stories with friends or finding humor in everyday situations helped me navigate the tougher moments. It reminded me that even in the midst of challenges, joy can still be found. This perspective is something I strive to share with my patients, encouraging them to find moments of lightness amidst their struggles. As I reflect on my journey from nurse to patient, I am filled with gratitude for the lessons learned. Menopause taught me that compassion is not just a skill, it's a way of being. It's about connecting with others on a human level, recognizing their struggles, and offering support without judgment. This understanding has transformed my approach to nursing and deepened my commitment to providing compassionate care. I encourage everyone, whether you're a healthcare provider or someone navigating your own challenges, to embrace the power of compassion. Let's break down the barriers of stigma and create a culture of understanding and support. Together, we can foster an environment where everyone feels valued and heard. Thank you for joining me on this journey today. If you found value in my story, I invite you